Thank you.
Thanks very much, Nita. Thanks everyone for your time and attention for this. So I'm a lecturer in pharmacology with a very kind of long-standing interest in research around Stevens-Johnson syndrome and toxic epidermal necrolysis. So what I thought I'd do today is just talk you through what we really understand from a scientific point of view, what we understand about SJSTEN, what we still need to know, and the research that's ongoing here in Liverpool to try and help fill those gaps in our knowledge. So next slide, please, Nathan. So my research really revolves around three aspects: whether we can predict an individual's predisposition to SJSTEN. Is there a test we can do which tells us that an individual is likely to get SJSTEN before they receive a drug, and therefore we can try and avoid it, like Anita suggested earlier? To understand how SJSTEN occurs, we don't have a very good understanding of some of the aspects of the skin injury that occur with SJS, and that's something I'm keen to understand more of. And if we can understand how it occurs, then we can start to look at how we can better treat it. So we're also looking at identifying and developing novel therapies for individuals who are unfortunate to get SJS without being able to predict it, but hopefully we can develop better treatments to help them and minimize their symptoms. The next slide, please, Nathan. So what we do know about SJSTEN is essentially in simplest terms, it's a reprogramming of our immune system to attack our skin cells. Typically, it needs a specific drug, and it needs a specific genetic variant, as Anita alluded to earlier. And those two together cause this reprogramming, which I'll talk about a bit more in a second. However, not all individuals with that particular genetic variant and the drug necessarily get Stevens-Johnson syndrome. Some people will get a much milder set of symptoms, maybe a rash, which resolves when the drug is taken away. And we don't understand why some people get a very mild reaction and some get a very, very severe reaction. That's something I'm interested in discovering more about. And we have some drugs which we know are effective, and I'll talk about those again in a second. We know they're effective, but we don't actually understand why they're effective, and that's something I'm keen to explore more as well. So next slide, please, Nathan. So Anita talked about some of the genetic predictors of adverse drug reactions. This is a list of the genetic predictors of some of the Stevens-Johnson syndrome reactions. And as the list suggests, a number of them are anticonvulsants, anti-epileptic drugs. And they have, essentially, if you carry any of these genetic variants in this column here, your chances, or your increased fold chance of having Stevens-Johnson syndrome by getting that drug. So for example, for this one here, is between 50 and 1,000-fold higher chance of getting Stevens-Johnson syndrome if you have that variant compared to not having that variant. We know these are some of the more common causes of SJSTEN, but these obviously, some of these epilepsy and HIV drugs, etc., are quite rarely prescribed. They're not prescribed more commonly as some things like paracetamol, aspirin, ibuprofen, which also cause Stevens-Johnson syndrome as well. And these are the ones that, these are the holy grail. It's identifying the genetic predictors of more commonly prescribed drugs, so that that we can minimize and predict those people who are at risk and minimize the chances of getting them by offering them an alternative treatment if we can identify the genetic variant. So I've highlighted this one in red because this is an example of the one in red is an example of a genetic variant we identified ourselves here in Liverpool to a drug called nevirapine, which is used to treat or was used to treat HIV. So if we go to the next slide, please, Nathan. So this is about as scientific as I'm going to get. So we have on all of our cells we have something called an HLA protein, and this essentially acts as a barcode. And this barcode exists to stop our own cells being destroyed by our own immune systems. It recognizes them as our own cells and it doesn't touch them. But it does also allow for any foreign cells, so bacteria, etc., to be detected by our immune system, targeted and destroyed, and make us better. So in the case of SJS, what happens is the presence of a particular drug changes the conformation of that barcode. And that barcode, from being recognized as our own cells, suddenly our own cells start to become recognized as foreign cells, and that's why our immune system then attacks it. So this works by this is a computer model of what we've done. So eventually, these proteins on our cells, they're sort of a shape. I like to sort of look at the shape of an open pita bread. When the drug, which is this bit in the middle here, drops into that pita bread, it changes its conformation, it changes its shape, and then our own immune system suddenly recognises it as foreign, and that's what caused it to attack our own skin cells. So we understand an awful lot about the immune side of things, but what we don't understand, next slide please, Nathan, is an awful lot of the challenges that there are out there. We understand an awful lot about the genetics for certain drugs, but we don't have any markers or predictive markers that are generalizable, that are general to Stevens-Johnson syndrome. So we know for some very specific drugs we can predict them, but we can't predict for Stevens-Johnson syndrome in a general sense. We don't have any reliable predictive or diagnostic blood markers. So for some diseases, so if you have liver injury, we have very good blood markers for predicting liver injury. We don't have any predictive markers or diagnostic markers for predicting skin injury. There's no markers at the moment for prognosis. You know, in some respects, there are markers of tissue injury or organ injury, which we can monitor to show whether a patient is recovering. For Stevens-Johnson syndrome, we don't have that at the moment. We don't have any relevant laboratory models. There's no good ways of predicting or testing Stevens-Johnson syndrome predisposition in a lab. And at the moment, unfortunately, there are no targeted therapies. We don't have any drugs which are specifically targeted to SJS. We can use drugs which suppress the immune system and the immune response in a general way, but there's nothing that's targeted towards the skin to treat SJS. So that's the bad news, but I don't want to end on the bad news. That, you know, this is the limitations of where we're at the moment. But we are, you know, there are steps being taken to address all of these. So next slide, please, Nathan. So this is something called the lymphocyte transformation test, and I'm sure some of you are probably familiar with this. So what happens is we take a patient's cells, their white blood cells, their lymphocytes, we then expose them to the drug which caused their reaction. And we look to see whether that stimulates growth or you know, a multiplying of those cells. And this just shows you that in patients, on the left is controls. These are patients who have never had a tolerance to drugs. And then on the right are patients who've had a Stevens-Johnson syndrome reaction previously. We've taken those cells, we've given them the causal, exposed those cells to the causal drug, and look to see whether their white blood cells multiply. And hopefully you can see anything above the dotted line would be a positive test. And hopefully you can see from this that actually the proportion of positive tests for even patients who've had SJS is very, very low. So it's worse than they're flipping a coin. So what we have at the moment, the tests at the moment are actually quite poor for predicting Stevens-Johnson syndrome, even in patients with a known Stevens-Johnson syndrome.
Okay.
Oh, I don't know who's got there.
Right. Could you ensure that you're on mute, please? I don't know who's not on mute, but if you could ensure you're on mute, that would be lovely. Thank you.
Thanks, Anita. So next slide, please, Nathan. Sorry. And for treating SJSTEN, so traditionally the main line treatment is to give high dose systemic corticosteroids, and the idea of the corticosteroids is they suppress the immune response. So there's an awful lot of talk of suppressing immune responses, particularly with COVID at the moment. A lot of these drugs work in a quite general way to suppress our immune response and try and dampen it down, because it's that immune response which causes the further damage to our organs, and in the case of SJS, to our skin. There's a drug which has been showing quite a lot of promise in treating SJS, and there's a number of studies which have shown it to be quite promising, called etanercept, and that's used to suppress the immune response in psoriasis and arthritis and other autoimmune diseases where our immune systems attack our tissues. And this just shows a study from Taiwan where, just two examples, you can see quite clearly after 12 days, this individual who was treated with etanercept has a quite remarkable recovery. The blistering and the sloughing of skin has receded quite spectacularly. So there is promise in that, and etanercept itself is shown to have to decrease the risk of mortality in the most severe cases of SJSTEN. So next slide, please, Nathan. I should also say although etanercept works very well, we don't actually understand how it works, and that's something I'm hoping to work on. And this was a study that I was involved in many years ago, looking at nevirapine, which is an anti-HIV drug in Malawi. And this is what really kind of got my interest in looking at this, is because we have patients who will take the same drug, they can have the same genetic risk factor, but they have a very different outcome in terms of their symptoms. So the person on the left here, they got a rash which resolved very quickly after the drug was removed. This lady had Stevens-Johnson syndrome towards the milder end of the spectrum, and this chap here unfortunately had TM towards the more severe end of the spectrum. So we don't understand why, despite having the same risk factors, some individuals have very, very different outcomes in terms of how their skin is affected. So I've always felt that instead of just looking at our immune system, we actually have to look at our skin. Next slide, please, Nathan. So this is just to show you what Stevens-Johnson syndrome looks like under a microscope. So if you imagine, I'm sure some of you have probably had a skin biopsy done. So this is a skin punch biopsy. It's done through the 3 layers of the skin, and it collects a part of the three key layers of skin: the epidermis, the dermis, and the subcutaneous fatty layer. And then what we do is we slice that very thinly, and we stain it, and we look at it under a microscope. So this is an example of a healthy skin. This is the subcutaneous layer here. This slightly lighter pink bit here is the dermis, and this very dark pink bit here, spotty bit, is the epidermis. In healthy skin, that's what it looks like. It's Stevens-Johnson syndrome skin. So if you can imagine, this core biopsy has been taken right on the edge of a blister, and hopefully you can see quite clearly here that the subcutaneous layer is here, the dermis is here, and then there's a very big gap opening up, and this would essentially be your blister. So we've started to look at skin like this under a microscope to try and understand, well, why is this detachment of the 2 layers occurring, and can we understand why it's occurring? And if we can we develop treatments or identify treatments which can stop this occurring? So next slide, please, Nathan. We've had some success. So we identified a protein. I won't go into the details of it, but we've identified a protein which is called HMGB1, and these are again 3 different skin samples. This one here is a healthy skin. Again, you see it's quite intact. This is a skin from a patient who experienced a drug-induced rash. And this is a patient who experienced Stevens-Johnson syndrome, but in this case, the skin hasn't yet blistered. And what's quite striking about this brown staining is where this particular protein exists. And it exists quite clearly on the epidermis, the top layer here, in a healthy skin. And again, it also appears in the rash patient skin, but hopefully you can see here that it's completely disappeared from this layer here. And this gives us an indication that there's a very early indication that there's something wrong with the cells in that particular layer, the epidermis, and that hopefully we could use this to predict early on that patients are starting to experience detachment of the epidermis, which causes the blistering. So we think this is quite a promising marker of early onset blistering in Stevens-Johnson syndrome. So that's quite a positive development. Next slide, please, Nathan. We also know that this particular protein, when it's thrown out of all of our cells when they start to become injured, it actually itself, it stimulates our immune system. And we think that by stimulating our immune system, it might increase the skin tissue damage caused by that immune response. And we've started to think about, could we block this particular protein as a treatment for SJSTEN? And I put here, does licorice hold the answer? Well, one of the most potent blockers of this particular protein is a substance called glycyrrhizin, which is what gives licorice its sweet taste. So we actually think that something which is a perfectly safe, healthy thing for people to ingest or to receive could actually be a potential in principle, a potential therapy for SJSTEN. Next slide, please, Nathan. And the hardest thing we have to when doing this work is coming by tissue, skin tissue from patients. Obviously, thankfully, these are very rare reactions, and we do struggle to get tissue. So we're developing ways of recreating Stevens-Johnson syndrome in a laboratory. We're doing this in a number of ways. We're looking at skin explants. We can take healthy skin biopsies. We can put them in a dish. We can grow them over we can maintain them over a number of days, and we can treat them with various different things. And we can look at inducing epidermal detachment, skin blistering, and we can look at mechanisms that that's occurring. We can grow skin cells in dishes where we can look at different mechanisms as well. And the one that I think has got the most potential in the future is this one, what we call 3D skin equivalents. We can take skin cells and we can create an artificial dermis and an artificial epidermis in a dish, and we can look at how the two separate from each other, and we can start to understand why the blistering occurred. Next slide, please, Nathan. And we've had quite a lot of success doing this so far. So we've taken biopsies from a healthy skin donor. We've grown them in the lab for 3 days, and we've treated them. We've taken patient blood serum from a patient with Stevens-Johnson syndrome who was admitted to one of the hospitals locally. We took that serum, we treated the patient with that serum, and hopefully you can see that the untreated skin is very different to the treated skin. This has started to detach quite a lot here. So we've managed to essentially recreate Stevens-Johnson syndrome of the skin in a dish. And this is fantastic. This is a really fantastic development, because we can now start to look at this to understand the mechanisms by which this detachment of the epidermis is happening. And we can start to screen through drugs. We can start to look at different compounds, different chemicals, which might act to diminish that detachment and act as positive therapeutics for Stevens-Johnson syndrome. Next slide, please, Nathan. And this just to show, this is the same experiment again, but it's just to show that our previous protein has the same effect. So we see exactly the same effect with this particular protein, where you can see hopefully the top layer here is lacking brown staining, as it did in the patient example. So this is a really promising, it really starting to show all the hallmarks of Stevens-Johnson syndrome type skin, but developed from a healthy controlled donor. Next slide, please, Nathan. I've also done a lot of thinking about other mechanisms which could cause Stevens-Johnson syndrome, epidermis, skin detachment and blistering. And one thing that struck me from various conversations with colleagues and collaborators was there's a similarity between Stevens-Johnson syndrome and epidermolysis bullosa. So if anyone's not familiar with epidermolysis bullosa, it's a congenital disease which affects young children. They're often called butterfly children because their skin's considered so delicate when it sloughs off and it detaches that it's almost like butterfly wings. So they look they don't look particularly similar in terms of the clinical presentation, but actually under a microscope they do look very similar. Hopefully you can see that the epidermis is detached in both of these very clearly. Now we know that epidermolysis bullosa is a genetic defect which causes a protein called collagen 7 to be malformed, and this collagen 7 is what holds the two layers together. And by being defective, it essentially allows the skin to separate very, very easily. So we thought about this and thought, well, maybe something to do with collagen is happening in Stevens-Johnson syndrome. So you can see that the two layers are detached. Is it because there's a defect of collagen in SJS that's causing the skin to separate? Collagens are crucial for holding the two layers together, so it's perfectly plausible that this might be the case. So next slide, please, Nathan. So this is a very colourful slide, but hopefully all I want to show you here is this is two pictures of skin. This is one which is untreated, and you can see the greeny blue layer here is the epidermis skin, and then the dermis underneath. And what we've done here is we treated the skin biopsies with nothing, and then we've treated them with the serum taken from the patient blood. And hopefully you can see quite clearly that this is significantly more green here. And what we think this is the activity of a group of enzymes called collagenases. So these are enzymes which digest collagen. So we can show that there is a significantly increased amount of these enzymes digesting the collagen in an SJS-like skin. And we've identified a particular protein which plays a role in this, which digests those collagens. And we think if we could target this protein, we might be able to find a therapy for preventing that digestion and preventing the detachment of the skin. Next slide, please, Nathan. So I've just simplified it a little bit here. So essentially, this is our two layers of skin, dermis and epidermis. And between those is a layer of this collagen. We think that when the cells are stimulated, they release this particular protein which digests the collagen and causes the detachment. And the beauty of this particular protein MMP9 is lots and lots of pharmaceutical companies have already developed drugs which act against this particular enzyme. They've proven them safe in clinical trials, but they haven't actually found a clinical use for them. Essentially, they've all fallen by the wayside because they've got no clinical use for them. So there might be a way that we can take these old drugs and repurpose them to treat Stevens-Johnson syndrome. And the other, I think, quite interesting thing about this is these particular enzymes are what are found in snake venom. They're found in snake venoms because they destroy tissue. That's what snake venoms do. And snakes carry an awful lot of proteins called anti-snake venoms, which neutralize these enzymes to stop the snake killing itself from its own venom. So we're now looking to do some work looking at anti-snake venoms, which might be potential therapies for SJS. Next slide, please, Nathan. This is something I think is really, really interesting. Mark, who's on the call today, is working on this, looking at hyaluronic acid as a potential treatment and cause of Stevens-Johnson syndrome. So we're investigating a whole group of chemicals which are called glycosaminoglycans, or GAGs. Two of those are heparin, which is a well-known drug for treating blood clots, and also hyaluronic acid, which you'll probably have seen various celebrities peddling on the television for their complexion. One thing we're exploring is whether hyaluronic acid could be used as a therapy for SJS. There's a particular mechanism we're looking at, which hyaluronic acid, we believe, inhibits, that might stop skin damage in SJS. But one thing I think the potentially most interesting thing about this is all of us have different levels of hyaluronic acid in our skin, and we're looking to see whether does hyaluronic acid level, low hyaluronic acid levels in your skin predispose you to more severe skin blistering than individuals with high levels who might just get a rash type reaction. So these are two compounds which we know are safe in humans that might have some really quite striking beneficial effects in SJS. So that's something else we're working on. Next slide, please, Nathan. So just to conclude, there's still lots of work to be done on predicting SJSTN. You know, I'm not by any means suggesting that we know everything. We really don't. The more we do, the more we learn. I think we're getting to a point where we can predict more and more different specific drugs. We still can't predict SJS itself, but I think we are advancing our understanding of what causes skin blistering and the epidermal detachment, which is obviously one of the most striking symptoms of SJSTN. And I think there are lots of potential new therapies out there that we could be using in the future. Next slide, please, Nathan. And I think this is a really positive thing. I have been applying for money to work on Stevens-Johnson syndrome for a very long time, with varying amounts of success. And the British Skin Foundation were up until a few years ago were very reluctant to support research on SJSTN, which frustrating. They used to just tell me that it was rare, which I think is an infuriating thing to say. They dismissed it because it was rare, and I'm sure everyone here wholeheartedly disagrees with that comment. But this is just to show we got some funding, a small amount of funding from them a couple of years ago, and last year they published this piece on their website. It's the first piece on SJS I've seen them publish, from Marianne, and her reaction to eye drops. So I think just to sort of sum up, I think the research community is becoming more aware of SJSTN and the problems of SJSTN, and I think they are willing to embrace it and to fund it more, not just because of the work we do and others do, but I think as Anita said, some of the immunotherapies that we're using for cancer treatment now have very, very high incidence of these reactions, and I think they're becoming more frequent in some fields, and therefore the research community is very interested in them. Next slide, please, Nathan. So I think this is my kind of wish list of things we need in the future, and I think Anita's making great strides in a lot of these. Certainly the first two. I think a database of patients, I think, would be a fantastic thing to have to understand frequencies. The MHRA does a great job, but you know, I think some respects, I think maybe we're missing some of the cases that are occurring, and it'd be great to have a more comprehensive understanding of who and how many people are experiencing SJS. A faster coordinated identification of those experiencing SJS reactions. So a lot of the work we do, or I do, relies on having samples from patients at the peak of their reaction. Serum samples particularly are of particular interest to us, blood samples at the peak of reaction. So being able to identify patients and recruit them much faster. I know Anita's got consent processes and ethics processes in place where we can do that now. But I think the most important thing, I think, is your support. We can't do this work without patient support and without the willingness of people to donate their time, their efforts, and their biological samples as well. It really is. It is. I do this because I want to make things better in the future for people like yourselves, and I hope that you'll support us in doing that. Next slide, please, Nathan. And I'm not, and at the same time, I can't take the credit for all of this work. It's really a team effort, and it's an international effort. There's collaborators that I work with from Taiwan, Spain, America, and Newcastle, and all my colleagues here in Liverpool. And I've just highlighted in bold my three PhD students, Nora, Amika, and Mark, who are all here today. They're all working on various aspects of the work I've talked about today. And I thank you very much for your attention. I'm more than happy to take any questions from anyone who has any.